Hey Savvy Social Workers, so in this part of the series on DSM-5 most common disorders and medications, we are going to be chatting about depression and mood disorders. So first off, let's define depression. Depression is an intense sadness that lingers for weeks or longer and accompanies other painful feelings such as worthlessness and hopelessness. To be considered as having major depressive disorder, you have to be feeling down and or have a loss of interest in activities that you previously enjoyed for at least 2 weeks. So remember, the duration has to be 2 weeks of consistent symptoms of feeling down and having a loss of interest for you to have a diagnosis of major depressive disorder, or for your client in any STEM, if they're giving you the signs, some signs and symptoms that sound like depression, if they say they're hopelessness and they say that, you know, the client's been feeling this way for the past week, well, then that's just depression. That is not going to be considered major depression. Next is persistent depressive disorder, also known as dysthymia. PDD is a chronic depression that is present for most days over a period of 2 years. So remember, major depression, that's 2 weeks. Persistent depression, that is 2 years. The symptoms are milder than major depressive disorder. So while a client is feeling those symptoms of depression, 2 or more of the following must also be present: poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration, feelings of hopelessness. So just remember, when something is persistent, it is a lot more long-standing, as well as it's going to have milder symptoms, but it has to be at least 2 or more of the following from that list in order to be considered persistent depressive disorder. During that 2-year period, the symptoms have to have not been absent for more than 2 months at a time. So if something is persistent, remember that it's going to be continuous. So if there was ever a period of more than 2 months where the client didn't have those symptoms, then it will not be considered persistent depressive disorder. It will be more along the lines of major depression or major depressive disorder. So these would be some of the medications to look for when major depression or persistent depression is diagnosed. But these medications can also be prescribed when there are both depression and anxiety symptoms. Now, a lot of them are primarily prescribed for depression, but whenever a client has anxiety that accompanies their depressive symptoms, then they'll also prescribe these medications as well. So these are known as the SSRIs, which don't usually have serious lasting side effects. So again, see the list here, but make sure that you are studying both the generic and the brand name. And I also gave you a list of some of the other diagnoses that these medications can be prescribed for, but remember, we are paying attention to the most common ones. And so definitely know, I know Lexapro is very common for depression, as well as Zoloft. Luvox, you may see that, as well as Prozac. Paxil, I'm not sure how common that is, or Celexa, but I know a lot of times you'll see Lexapro and Zoloft for sure. And sometimes I've seen Luvox in a couple of questions, but just to be safe, know them all, brand name and generic name. And remember that these are the SSRIs, the ones that don't really have any serious or lasting side effects. Now, let's get into bipolar disorder, which you are likely to see on any and every exam. For starters, bipolar disorder is a severe mental illness that produces intense emotions and responses at any given time, okay? Although they usually occur spontaneously, the conditional moods can go from being happy to extremely sad and confused, which is why they call it bipolar. And some people say, oh, you know, they change like the weather, all those things. Okay, so understand that most of the time it's spontaneous, and the moods can go from high to low really quickly. For exam purposes, you will have to know the difference between bipolar 1 and bipolar 2. A lot of times they don't just ask you about bipolar. They will be specific in seeing if you are able to identify whether it's bipolar 1 or bipolar 2. So bipolar 1, the defining feature is mania. It represents a distinct period of elevated or irritable moods lasting for at least a week. So when the patients or the clients are in this manic stage, they have an elevated mood. They're irritable. Sometimes they feel like they're on top of the world, and they're not really getting any sleep. So they are euphoric, grandiose, anxious, or irritable, and even enraged sometimes. They have racing thoughts, pressured speech, impaired judgment, and risky or inappropriate behavior. So just think of mania or manic, or just think of, what they refer to as a maniac. All of those things, all of those symptoms that would accompany that: increased energy, the decreased need for sleep, just feeling like, they can conquer the whole world, they can save everybody, increased sexual drive, decreased attention span, substance abuse, and impulsive behaviors such as spending sprees. That's a big one. The substance abuse and the impulsive behaviors, spending sprees. Y'all make sure y'all kind of know that these are common symptoms of bipolar 1 when they're in that manic stage, and it could also result in psychosis, which could land them in the hospital. Okay, so bipolar 1, mania is the defining feature to remember. Now, bipolar 2, the defining feature is the opposite of mania, which is hypomania. The DSM-5 classifies a hypomania episode as the presence of one or more major depressive episodes. So the first one was in like an upper situation. This one is more of a downer situation, and at least one hypomania episode. Okay, so the hypomanic or the hypomania episode must last for most of the day, each day, for at least 4 days. Okay, so in order for it to be considered hypomania, bipolar 2, it has to be going on for 4 days. So I want y'all to remember that duration. So here's how hypomania differs from mania. Number 1, it is not as severe as the manic episodes, which may require hospitalization, and that's because of the psychosis a lot of times. And hypomania does not involve psychosis, which is why it is not likely to require hospitalization. So definitely know the differences between bipolar 1 and 2, which is again mania and hypomania. Hypo, just think of something on the lower end, so that's going to be the depressive episodes, and the mania is going to be on the upper end, where again everything is just, you might as well say, elevated with them. Okay, cyclothymic disorder. This disorder is assigned to individuals who experience mood cycling over a 2-year period, but have not met diagnostic criteria for bipolar 1, 2, or depressive disorder. So these people are just kind of cycling around in the middle. Their time frames or their durations are not adding up to be officially classified as one of the other 3 diagnoses mentioned. So that's kind of why they are referring to it as cyclothymic. And so just remember that they're kind of cycling probably through all of them, but not consistently enough to have the official diagnosis. So for at least a 2-year period, there have been episodes of hypomanic and depressive experiences which do not meet the full DSM-5 diagnostic criteria for hypomania or major depressive disorder. So the same thing I just said, it's just that you'll see the signs or you'll see the symptoms, but they don't last long enough to meet the criteria for an official diagnosis. So just know that for at least 2 years, they're kind of cycling through all of those signs and symptoms. So for this to be an official diagnosis, that above criteria has been present at least half the time during a 2-year period, with not more than 2 months of symptom remission. So again, they're having symptoms and they're not going longer than 2 months without any type of issues. And so that's where they're going to be, you know, just kind of in that cycle and meet the criteria for cyclothymic disorder. So for at least a 2-year period, they have to have been having episodes of hypomanic and depressive experiences, right? But not enough for it to be classified as depressive disorder, bipolar 1, bipolar 2. And also, within that 2-year period, it has to have been going on for half the time, right? So let's just say at least a year, and even if it's a year long, it still cannot be more than a 2-month break at any period of time within that year. That is going to be distinctive, okay? So I'm stressing that because that is very distinctive for this disorder when you are diagnosing. I haven't really seen many exam practice questions that are asking you to diagnose specifically this, but I have seen questions where you have to at least know what it is. And here are the medications for mood disorders. Lithium, which is very common, Tegretol, and Depakote. These are the most common. And then you have the anticonvulsants, which is Carbatrol and Topamax. And so these medications are prescribed for the mood disorders, bipolar disorder, seizures, panic attacks, nerve pain, especially the anticonvulsants for seizures and panic attacks and nerve pains like that. A lot of the 3 at the top are prescribed for bipolar disorder. They are the go-tos for bipolar disorder. The most widely used is lithium, but lithium can be very harmful to the kidneys and other organs if it's taken in too high of a dosage. So in order to prevent this, the physician has to monitor the amount of lithium. So this is where you'll see a client coming in monthly to do blood work, to monitor those levels, making sure they're not getting too much. So before they will get their new lithium dose, they will have to submit blood work, just because you want to make sure you're not overdosing them on the lithium, because again, it's harmful for the kidneys and other organs. Y'all, this is very important to know for the exam because you're likely to see it in a situation. So definitely know the seriousness of lithium. And if a client has an issue about why they have to take blood tests, it's because they're taking lithium and it's to preserve their life, pretty much. Okay, so just kind of know the brand names as well as the generics, because they could tell you either way. I will tell you, I have never really seen lithobid for lithium. They always just say lithium. Now I have seen Tegretol both ways, and I have not really seen Depakote in a question as the generic name. So that's not to say you won't see it, but I'm just trying to give you the most common things so you won't overly stress over studying things that are probably not even necessary. Now, I also will point out that if you notice, Tegretol and Carbatrol both have the same generic name, and I have researched it, and they come up the same. So just kind of know that those that are ending in the OL, that they have the same generic name. That is not a typo. It is definitely a fact. So yeah, that's what I have for depression and mood disorders. I hope this was helpful. I will be coming back with another video, and I think I will be touching on conduct disorder versus ODD, as well as DMDD. So stay tuned for that video. Again, thank y'all for being here. Thank you for your support. Always, please just like, share, comment if you feel the need. And continue to tune in. Thank y'all so much.